We'll get started here in just a couple minutes, just giving folks time to join. Okay, it is 1:30, so we'll go ahead and get started. I'm sure we'll still have a few folks joining us. So I'll try to continue to keep up with admitting those. But thank you everyone for joining us today for the final session of the Long-Term Care Antimicrobial Stewardship webinar series. I'm Loretta Fitzgerald with KFMC Health Improvement Partners, and I'm really excited to have the opportunity to learn from Dr. Kelly Wark again today. Today's presentation is focused initiatives directed towards shorter durations for antibiotics. So before we get started, I do need to remind you that if you're seeking CNEs, please remain on for the entirety of the presentation. And also please complete that program evaluation form, which will pop up at the end of the webinar. If for some reason you close that window and don't get that, you can email me and I will send you a paper copy of that. Certificates of attendance and CNE will be sent out via email, and we are recording today's presentation and it'll be available on our website very soon. The completed webinars of this series have already been posted, so feel free to share those with your colleagues. It looks like they've been shared quite a bit already. Let's see here, what else? If you have any questions, please do reach out and feel free to place questions into the chat at any time throughout the presentation. So in case anyone is joining us for the first time today, I'll reintroduce our presenter, Dr. Kelly Wark. She's an assistant professor of infectious disease at the University of Kansas Medical Center, as well as the subject matter expert of antibiotic stewardship, healthcare-associated infections, and antimicrobial resistance in the KDHE's HAIAR section. At KDHE, she is the antimicrobial stewardship co-lead, and at KU, she serves on the antibiotic stewardship program and is co-chair of the vaccine and ambulatory subcommittee task force groups. Please welcome Dr. Wark.
Thank you, Loretta. Next slide.
Oh,
Yeah, next. So yeah, today, so our final kind of topic today was going to be a wrap up, and I feel like it's kind of a consolidation of all the prior ones, really, but like focusing on duration wise, because this has been really a big move in the past decade, is trying to cut down these excessively long durations into only really what's needed to cure these infections in efforts to reduce those side effects, those adverse events, and subsequently resistance. So we're going to talk a lot about like maybe the first third about the kind of like a lot of the literature around that and the evidence that supports these shorter courses. Because I know that's always important to build on those guidelines to really convince clinicians that this really is the way that we should be moving. And then finally, I was going to briefly talk about some prophylactic use, but the bulk of our discussion is going to be on the shorter durations. Next slide. So this is I just want to like kind of it's amazing where we forget how important and how impactful antibiotics are. So this is an IDSA position paper. You can see the differences in the pre-antibiotic era death rates for some of these really common infections that we have. So like pneumonias, heart infections, bloodstream infections, they were killing 100% of people before antibiotics 100 a little over 100 years ago. But you can see here the change in mortality with those antibiotics. So we're talking like they drop these by like 70%, 60% for endocarditis, 75%, where virtually everyone would die before the advent of antibiotics. And, so we get so much wrapped into so much technology or the newer things, but compare this to something like someone comes in with a heart attack for a fibrillinic in the ER. This is such a big push for this. Like, get them that fibrillinic, that case or streptokinase right away. But like that only has a 3% reduction in mortality. So just like emphasizing how like because we're just so used to it. This is where we've only been alive with antibiotics, but remembering really the importance of these. Next slide. So this is my off-cited. I love this graph. I just or this it was a randomized control trial that this group did, Malhotra and Kumar. And so what they did is because I just think this demonstrates everything about like why the longer durations, how they impact resistance. So they had this group of people, all normal people without getting treated for an infection. But what they did is they had a group that got antibiotics, either clarithromycin or azithromycin, so the macrolide antibiotics, and they got this other group that was just the control groups. They got placebo. They didn't get any antibiotics. What they did is they swabbed their throats up to 6 months. And you could see here by day 4, so out of that group that was getting those antibiotics, already by day 4, that resistance of their strep in their throat had already tripled. So 4 days, tripling of that streptococcus pneumoniae in their throat. And then they kept following this over time. And actually by 6 months, that group that got those antibiotics, so their antibiotics were long gone, completed, but that resistant strep sustained their up to 6 months. So just kind of the impact that a lot of these antibiotics and the long durations can do. Next slide. So then this is another one for strep throat, where they actually looked at a shorter duration, a shorter 5-day duration, for a longer 10-day duration, and so you could see that the shorter resistance. So 5-day course of amoxicillin had resistance of the strep by about a quarter, and then when you increase that up to 10 days, you double the days, then you get up to more like a third of those bacteria resistant to that. So just the more pressure you have for those bugs, just really the ones that are surviving are the ones that are resistant, and that's what we're going to be left over with. Um, UTIs too. So this was an interesting study by Metley. They looked at all these different antibiotics and the impact over time with their drug resistance. And a course of Bactrim for a urinary tract infection, any course over the preceding 6 months was associated with an increased risk of just colonization or carriage of a drug-resistant bacteria by like fourfold. So, and that effect sustains, up to a year. I have some slides in the subsequent ones that kind of go over really large volume studies that have looked at this. Next slide. I apologize for my voice too. I'm getting over like a 2-week bronchitis, and it's still a little scratchy. So where did these like the durations come from? So reading back on this, this is a study or a kind of commentary by Rice, like about 15 years ago. Kind of goes over the history of durations, and it's really interesting because when these antibiotics were like the first penicillin studies, I mean they were using one dose, 1 to 2 days basically of the penicillin. It wasn't like a 10 days, 20 days, et cetera. It was really just like 1 or 2 doses for a lot of these infections like pneumonias and such. And really, the early trial, they weren't really like, like these robust trials, but they, commented in these early studies that they published on antibiotics that really most of the patients were treated for 3 to 4 days, so really short durations, and they were cured. So where we get into the longer courses, we moved on to the 50s and 60s. So that's like the golden era of antibiotics. There was all these antibiotics that were being discovered, but also manufacturers wanted to make a lot of. I mean, they were they this is a company, and so they really were pushing a lot of use. There was a big scandal with the FDA director. He was actually also the publisher of a journal called Antibiotics, and he was accepting large sums of money to preferentially publish certain manufacturers antibiotics, and they really promoted longer courses because the longer duration, the more you're buying of that, then the more that they're making. So that was kind of a big scandal, and so anyway, these durations got extended so long, and then we kind of started to kind of come the other way. So in the 90s, so like the CAP guidelines, they made in the guidelines, they actually state, we are not aware of any controlled trials that address how long we need to treat for pneumonia. So they called that out in their guidelines, and then subsequent guidelines have continued to address this, duration issue. Same thing for the travelers diarrhea guidelines. They call out, you know that one day appears as effective, but they still recommended 3 days. And the same thing was with the meningitis guidelines, that this wasn't really based on like evidence necessarily, the duration, but that's kind of what was chosen by expert opinion at the time. So then, as you're aware, in the 90s and 2000s, when we started to get more resistance, the first there was a lot of effort to reduce antibiotic use. But Rice, a professor, I think at Brown, he made the suggestion that, maybe we're not going to impact like stopping antibiotics for like viral respiratory infections, or we're not going to stop maybe all the antibiotics for asymptomatic bacteria. But what we can do, we can cut the courses down. And so that was kind of a new strategy. And then over the past decade, there has been over 120 randomized trials, many types of infections, so pneumonias, bacteremias, skin infections, osteomyelitis, ear infections, septic arthritis, all these types of infections. And I'm not going to go obviously through all of those, but I'll go through kind of the most pertinent that's going to happen that you guys are going to see for your population for pneumonia, UTIs, and skin and soft tissue infections. And I didn't include it here, but Dr. Brad Spellberg, if you want to go to the next slide, Loretta, he's kind of been the big push for this kind of mantra. It's called Shorter is Better. And he has this website. You can go to this, just Google Shorter is Better. He has like a whole website that has a running tally of all the studies that come out and what kind of condition it is. I mean, there's stuff on malaria, there's, so many different topics. And you can see that really the shorter versus the longer durations, and what the evidence is right there. But he did this commentary a year ago in Clinical Infectious Diseases, and it's kind of funny because it is true. But what he calls out is like it's like we started using Constantine units to describe our courses of antibiotics, meaning like 7 days. So the Constantine unit as like the 7-day week, and it is true because what we tend to prescribe is 7 days, 14 days. They tend to be these kind of same durations, these weekly durations. He suggested maybe if Constantine has chose a 4-day week, instead of doing 7 days, we do 4 days, 4-day courses. But it is kind of like a dogma that we tend to stick with kind of these same numbers. But it doesn't mean that it's based in like reality. Next slide. And so yeah, so the gold standard for duration is just really not there. And as we've kind of are seeing is that really we're way over treating so many of these infections. We of course as clinicians we get worried about. We want to make sure that we cure something. So we want to give them enough duration to cure that infection, and balance that with not doing too much antibiotics. That that we're having increased adverse events, the resistance, but of course just the cost of more antibiotics. Next slide. So this was a huge analysis of 35 systemic reviews, and then they looked at these trials, 71 trials that looked at short durations versus long durations, many types of infections. Was over 23,000 patients involved in all this meta-analysis. They kind of got like this incremental daily dose where you can kind of get an estimation of how much extra you're getting with each day of antibiotic. So per daily addition of antibiotics, your adverse event is going up about 4% per day. Antibiotic resistance about 3% per day. Secondary infections about 2% per day. And then just really like when you look at the extra shorter course of 3 versus 5 or 3 versus 7, if you're comparing that shorter 3 day versus that 5 to 7, you're getting into many more. So 19% increase odds of adverse events if you're doing a 3 day versus a 7 day. So just a lot more things can happen the longer that people are taking these antibiotics. Next slide. So this is from the American College of Physicians, and they a couple years ago they put out the guidelines actually, and they recommend clinicians to really cut these durations down. And so this is kind of a graphic from the ACP, and here's the citation for the shorter course, so you can kind of get more details on what they were advocating for. But really, what they recommend for clinicians, so American College of Physicians, so like basically all physicians group for COPD or bacterial bronchitis for 4 days of antibiotics, to community acquired pneumonia to 5 days, and then urinary tract infections for 3 to 5 days. And then they give a little bit more specific details for that, kind of like what we talked about in our first session for types of antibiotics. For instance, you can give 1 day for fosfomycin, or 5 days for something like nitrofurantoin or macrobid. And then for cellulitis, 5 to 6 days. Next slide. So first, we're going to go over some of the literature around pneumonia. So for pneumonia, there's been at least 14, as of a couple months ago when I last searched, 14 randomized trials. So comparing short durations to that same cure for long durations. They looked at either 3 or 5 days and comparing those to longer courses up to 14 days. And they found that there's pretty much agreement in those 14 trials that the shorter 3 to 5 day course had equal cure as those longer courses. So 14 trials comparing those durations. So pretty good evidence there. Next slide. This is some additional citations, and you can see where kind of the type of antibiotics that they use. So a lot of them are shorter courses. You can see amoxicillin for 3 days versus amoxicillin for 8 days. No difference. 119 people. You can see all the numbers that are treated there. So pretty good evidence that we are kind of doing too long a courses, and really it seems like a 5 day course is probably pretty good for the bulk of most pneumonias, community acquired pneumonias. Next slide. This is a separate analysis, meta-analysis, where they pulled all those community-acquired pneumonia trials of the shorter and the longer durations, and they looked at the longer-term outcomes. So they looked to see, are these people having recurrent pneumonias if they're treated with at these shorter 3 or 5 durations, and is there any associated increased mortality? And indeed, you can see from that forest plot there was no difference in the shorter course for mortality or having them get readmitted and having recurrent pneumonias with the shorter courses. Next slide. And then here's another meta-analysis where this is actually what they looked at for drug resistance for respiratory bacteria, and they looked at, it was 7 studies where they looked at people that had been treated with antibiotics for pneumonia, and then you can see really, and then they followed them to see the resistance respiratory flora. You can see really the greatest risk of that resistant bacteria is in that first month, but all the way to 12 months, it's sustained resistance. I mean, so twofold increased resistance of that bacteria in their sputum up to 1 year. So really, as much as we can go, so go back to those first slides. The more you cut down on that duration, the less you're driving this resistance. So really, just as much as we can cut those down, will really, I think, will help this resistance problem. Next slide. So another topic on the kind of a not necessarily a shorter duration top, it is shorter for azithromycin, but another thing to really be aware of is this, especially for elderly, this azithromycin issue. So for community acquired pneumonia, where we get a lot of people that are treated with azithromycin or these Z-Packs, this is a couple of studies. This was one in the New England Journal of Medicine, and they actually looked at these Medicaid beneficiaries, and they looked at people that took 5 days of azithromycin or 5 days of amoxicillin for these pneumonias. And what they found, those people that took that azithromycin, they had almost a threefold increased risk of cardiac related death. So they actually were able to kind of estimate from that kind of this large volume study that there was about 47 extra cardiovascular deaths. So these were mainly heart attacks and sudden cardiac deaths is what they found, but some cardiac arrhythmias too. But per million Z-Pack courses, 47 cardiovascular deaths. So, I don't know how many millions or maybe billions of Z-Pack courses we do, but that's a significant amount. And since the group that is at greater risk really is the elderly, this was a recent that just came out in ASHI that kind of estimates how many Medicare beneficiaries are getting azithromycin. So indeed, it is the third most commonly prescribed antibiotics to people that are 65 and older. So this is a really, something we should be really cautious about. Trying to avoid azithromycin if there's alternatives, not to use that. And of note, in that large trial where they looked at all this outpatient antibiotic prescribing data, the Midwest was actually the second highest prescribing state for those. So the worst was South. They're always the worst. Sorry about that. There was a notice that came up. But really, we're second worst or second highest prescribing in the Midwest. Next slide. And then this was just another trial, I think this is the JAMA one, where they looked at VA patients again for the azithromycin for community acquired pneumonia, and it confirmed the same thing. It was the year after that was 2014, I think, and they confirmed that indeed it looked like myocardial infarction or heart attacks is what people had a really increased risk of once they were getting that azithromycin, and that risk actually was sustained up until 30 days after their azithromycin course. And then they compared that to all other causes of death. They compared it to different antibiotics and didn't find that risk of death. So it didn't seem like their infection was why they had the death. It really seemed like it was something specific to azithromycin. So actually, FDA put out this notice for azithromycin, calling on healthcare professionals to really be cautious with the use of azithromycin. Try to use alternatives, and especially avoid it in people that have a history of, prolonged QT, or they're on medications that prolong their QT. So people like that have AFib, it's our population really being considered, trying to get a different antibiotic for that population. People that have slow heart rates or bradyarrhythmias, people that have even they called out heart failure to avoid azithromycin, people that have chronically low magnesium or potassium also avoid. So big population, the FDA called it out that we should try to avoid azithromycin in that population. Next slide. So that being said, there are some situations though that look like they do favor a longer course. So specifically, some bacteria like Pseudomonas or Staph aureus or MRSA, or some bacteria like Burkholderia or some fungal infections. Those really are, they have better outcomes when they do have a longer course, more to the 10-day course. So that is a caveat to that. So more you're thinking kind of like the healthcare associated pathogens. Also, the other things is, if we're seeing someone like has a lung abscess or like a super bad necrotizing infection after like a flu, those situations definitely warrant longer courses. If they had a complication like a meningitis or an endocarditis or something like that, again, those definitely are not the situation where we're talking about that can get away with a 5-day course. Next slide. So next topic for shorter is the UTI and Pylo. There for these, both of these, there's 9 trials where they looked at the randomized trials. So they compared the shorter and the longer duration. All those found comparable cures for complicated UTI with that 5 to 7 day course compared to 10 to 14 day course. So a 5 or 7 day course of complicated UTI cured as many as the longer course. And then for pyelonephritis, usually this is a condition where a lot of providers do tend to treat for 14 days, but we're starting to push this down to really, 5 to 7 days, also as long as a complicated UTI. Basically, there is some caveats around this that you'd want to have like a specific antibiotic, like a fluoroquinolone or Bactrim, really would be more is for that shorter course. It's the 5 to 7 days were as equal to cure as the longer course. Next slide. And then here's some additional trials where you can see kind of the durations where they compare the shorter to the longer and the number of people and really the lack of any difference for the long and the short courses. I didn't specify in here which were UTI and pylos, but really, yeah, I can't remember at this point. I should have clarified that one, but it is kind of a mix of pylo and UTIs. Next slide. And then here, going back to that meta-analysis, this is where they pulled out the UTI data. So antibiotics for UTIs, there was 8 studies that they were able to include in that meta-analysis. So specific for UTI received antibiotics, and then the subsequent resistant bacteria developed. So antibiotic use for UTIs, they were associated with around a 4 to 5 fold increase in drug in antibiotic resistant E. coli. So you can see again, the effect seems to be strongest in that first month, but this one too held up all the way to a year. You can kind of see at that top part was 0 to 1 month, and then it kind of is getting closer to one over time. But it's sustaining, like long term impacts that we are going to be at increased risk of resistant bacteria after any antibiotic course. Next slide. So the next one we are going to go over is the skin infections. I think there's definitely, I would say the number one amount of evidence is definitely pneumonia and then UTIs. Not as many, but still quite a bit for skin and soft tissue infections. So there's 4 of these trials where they looked at the short and the long courses. A lot of people, so over 1,400 patients that they did a look like did examine, and the durations that they examined is anywhere from 5 or 6 days up to the 10-day course. And all of those 4 randomized trials, they found that shorter 5 to 6 had no less cure than the double that course. So again, just a shorter course cured these people just as much as the 10-day course did. Next slide. And then this was a couple separate other trials. Well, not a trial. The first one is where there was it was actually in rural Alaska, and they looked at receipt of antibiotics for any antibiotic, actually, not for an antibiotic. And then what they looked at is for subsequent people that developed MRSA skin infections. They found that had people received an antibiotic, they subsequently were at threefold increase for getting a MRSA skin infection, and that in anywhere in the preceding six months. And so there was another one where they looked at kind of MRSA colonization, and actually this one is in children, the second citation, but still it is impact because we're frequently all of us, many are colonized with MRSA. So antibiotics in those preceding years, so 12 months of antibiotics, increase your risk of getting colonized with MRSA 16-fold. So quite a bit, So again, we might get infections, but we might just get colonized with MRSA because of our course of antibiotic. Next slide. And then finally, the last one that I was going to review is diabetic foot infections. Another one where it's starting to get more literature supporting shorter courses in diabetic foot infections. This was a trial where they looked at people that had severe, actually moderate to severe diabetic foot infections, but they didn't have osteomyelitis. After they debrided those, people got either the 10 or the 20 days of antibiotics, and they were all oral, so there was no IV courses either. And they found that there was no difference in the cure for that shorter 10-day versus 20-day course. So really, this is another thing that we are really in ID starting to cut back on as these diabetic foot infections, and trying to minimize the, especially after debridement, because if you get a lot of that, dead infected tissue out, I mean, how much more antibiotics do you really need to treat whatever is left there? And for that one, I will say there is a really large trial that's underway. So more evidence to come, hopefully, and even maybe even shorter courses. Next slide. So just kind of a takeaways. So again, this is kind of a graphic that I did of the ACP Rex, but the COPD for like four days, or bacterial bronchitis, community acquired pneumonia for 5 days, urinary tract infections 3 to 5 days actually, and then cellulitis 5 to 6 days. Next slide. So for the last half, we're going to go over some of the interventions that we can work on to improve these durations. Specifically duration oriented. There is so many things, honestly, that could be done. So, kind of the graphic here on the left, there's decision support tools. I'll show you some of those kind of that we've created. Also, just the backbone of any of this is really your guidelines. So, the guideline provides that kind of consistency across the facility, but also it enables and empowers nursing and pharmacy to really this is our facility guideline. This is the standard of care for our patients. So this is, what we recommend here kind of consistently. So just again, it provides a little bit more support when you're trying to make these changes with prescribers' habits. Certainly education is always a part of this, to kind of like this, to show the literature, show that these shorter courses do seem effective. I don't really go into it with this one, but we've talked about it in the prior sessions about communication training, because that's a really important component of it too. Any stuff too, like antibiotic timeouts, audit and feedback. We'll go over audit and feedback, but all of those things can really cut down on these durations for your facility. Next slide. So the first one I'm going to review, this is like the most simple thing that could have been done. So in the order set, all they did was turn on the ability to hit the button in the order set. So when you go to click the order set, instead of just having it an open-ended duration, they put it in as a 5-day button or a 7-day button. For certain antibiotics, they did choose a 10-day duration. So things like that were for like amoxicillin, where you might need a 10-day course for like strep pharyngitis. So they did put a 10-day for like amoxicillin. But all they did is they turned on this functionality to click the button instead of having the clinician have to enter, you know, free text, enter, whatever they chose to order. And actually, you can see once they empowered this button, that was already a part of their EMR. So they didn't really have to do a lot of work for this. They just had to kind of turn it on. That was in 2015, and you can see what happened to their duration. So it just tanked, So people were able instead to just like free text, but yeah, I'm going to do 14 days for this pilo. Instead, they had that it was visualized to them to do 7 days, and then that's what they did. And so you can see here, what happened is those really longer durations, those 10-day prescriptions, they fell 16%. Certain antibiotics in particular were fell greater than others. So, like for instance, clindamycin, it dropped off; it fell 20%. Cephalexin courses or Keflex, those fell 10%. And then the shorter duration. So we cut down on the longer 10 or 14 days, but what happens is the 5-day duration, so those did increase, but that's what the goal was. Next slide. And so they also looked at kind of the longer term secondary outcomes. So they wanted to know, we're doing these shorter durations. Is this going to impact any revisit? So is this person not cured with their skin infection? Are they going to come back to the ER, or the clinic for another visit? Indeed, that did not happen. So there wasn't any increase in revisits. There wasn't any increase in hospital admissions. And actually, so also they looked back and saw, was that order order was it reordered? If so, like say someone got a 5-day course, was another order had to be placed for say another 5-day because it didn't cure. And indeed, that didn't happen either. So there was no difference in the antibiotic reorders. So really, what this group pointed out was like low cost. I mean, this was already something that their EMR had the ability to do. They just had to have their IT basically turn it on. So they didn't have to get, add-on or third-party vendors for the super expensive intervention. That's something that, we can just, already have or already have on our order sets is the option for these durations. Next slide. So this is a big trial that's ongoing, and this is an audit and feedback in Canada. The Health Quality Ontario, the Department of Health, is kind of this is a big project in their province, but it's for nursing homes. There is 360 clinicians or prescribers at these that are enrolled in doing this kind of prospective trial. This is the first one that they published a couple years ago, so I imagine they should be coming out with more evidence. But the first one they published is basically on their work on audit and feedback. And you can see here, this is something that they provide. So the graphics on the right is an example of what they gave to the prescribers at these nursing homes. It's kind of a report. So they gave half of the prescribers, they're giving just a like a printout of their prescribing habits quarterly, and they have a multitude of different kind of things they're tracking, and I'll show you those. But the other option that they're giving to the other half, so this half is getting just this really blank kind of report or like bland report. A second group is getting more of an interactive online report that then has links to their resources, links to their evidence. That they really is really more of an interactive type option. So they also did in this citation is one where they really interviewed the clinicians that are involved in this to get their feedback on these reports, what they liked, what they didn't like, what their perceptions were, and really what the feedback from these nursing home prescribers that they really thought this was they were visualized really well and they liked the resources. They did, put that there's interested in kind of they wanted to know their feedback or they wanted to know their prescribing habits compared to their peers, and they definitely wanted their prescribing habits compared to, a lot of clinicians are going to several nursing homes, so they wanted to see how that compared to their other, they're going to this one and this one, how is it different in those sites. But they all generally said it was very helpful to see the prescribing at their home level. Next slide. So this is an example of kind of one of these reports that they would get back, and so this is one that they provided on the prolonged treatment. So you can see how many of my patients were prescribed treatment courses by me over 7 days, and you can see they give them this rate of like 9.6%, and then it compares to their peers. So this one is lower, and then kind of gives them more details on the right of how many courses were calculated that, and then gives them the trend over time. Next slide. So they gave several different. I included just a couple of the things that they're tracking or their report gives provides back to their clinicians. But this is a in that same report that would give them their prescribing by if like they're going to multiple places. So this shows how what their rate is at their facility A, facility B, and C, so they can see how this individual clinician is prescribing at different places. And again, this is like a 7-day duration. And then this one is basically just what total percentage of their patients that were prescribed antibiotics. And then what this with basically this is the interactive one where it gives details on the report. So you can click, it links them to kind of the recommended duration, the evidence, it links them up to kind of infographics and communication strategies like you can see on the right, and I have some it's kind of hard to see on this screen, but I have some close-ups if you want to go to the next one, Loretta. So these are a couple of those Public Health Ontario infographics that they've done. The both kind of posters, but you can kind of see here they're focusing on duration for these big things that we talked about with the UTIs, the pneumonia, and cellulitis, because that's what they have identified in the three biggies in the nursing homes. And so there's the links also there if you are interested in any of those. Next slide. And then also what they do is they provide the evidence brief. So kind of what we've talked about today, but it's in this kind of 10, 11 page kind of like toolkit, goes over the evidence, gives more links to stuff, kind of gives information on types of antibiotics, types of communication strategies and stuff. And they have three of these guides. Again, all the links are right there. They have a cellulitis one, they have a pneumonia, and then on the next slide is the UTI one. And then also, this is a little bit separate project, but what Ontario, we talked about this in the first session, is the UTI program. This is actually another thing that Public Health Ontario has worked on, is creating these UTI programs for nursing homes. And there is that guideline, or their guide, their toolkit for how to start this kind of UTI program. So I just included that also there. Next slide. So this was so as I said, that trial is underway. The first one is just more describing kind of a qualitative. This one is that is specific to nursing homes. This one is an example of an audit and feedback project that happened in an ER. And they looked at this over the course of 6 months. So they gave what they did is they get these monthly kind of reports basically back to clinician prescribers, and they compared them to their peers. What they found over the course of time is that they decreased the median duration of antibiotics by 3 days. So that's a pretty big difference that they were able to cut back from 9.5 days to 6.5 day courses. They actually decreased the amount of double antibiotics. So people that were getting dual, say, you know, doxy and cephalexin in the ER, whatever. So they cut down those to just giving single regimens by 8%. Again, and really big impacts on clindamycin. So over a third a reduction in clindamycin. And then just this was kind of because they also did include an order set as part of this. So it was also just more, this was for skin and soft tissue infections. So they increased their uptake of kind of narrow regimens with cephalexin. So, an example, this isn't the exact peer report, but the University of Nebraska, their ASAP website actually has this where you can go and download this. This is an example of a peer report. You can see here where you can put in the types of antibiotics and the starts, and this is specific to nursing homes, and then you can compare it per providers too. There is actually a couple of these peer or these of these reports. So certainly go there and check those out, because I think they are pretty good. This one I kind of like better, but there's another one that you can check out too. Next slide. So, a larger kind of systematic review. So, they looked at interventions that were directed to physicians in providing advice or feedback, and they found that really that feedback was more effective in and sustained over time. So, that was 29 studies that kind of confirmed that. So, both are pretty effective, but really, this audit and feedback is one of the more effective ways that you can improve antibiotic prescribing. They found that really they did more of like a kind of a qualitative stuff too. They found that like interventions that applied these rules, so that would be an example of like a prior authorization, so where they have to prescribe in some way, they those so so to get this antibiotic, I need to fill out this form, or I need to get approval from the pharmacist. In this trial, these meta-analysis, they weren't nursing home specific, so they were across the healthcare spectrum. But they did have a qualitative part where they had feedback from clinicians, and this is always as a feedback, that those things that where you restrict antibiotics does kind of reduce that autonomy of clinicians, and there was that perception that it delayed treatment. So really, this audit and feedback doesn't get into that kind of mess of really where you're hampering the ability to treat people. You just cut down on the durations. Next slide. So next we're going to talk about guidelines. So again, kind of what we built on the prior sessions too, but really you need to have that strong kind of framework to build anything, to build your order sets, to develop kind of your communication strategies, to do your clinical decision support. It all kind of stems on really your developing a guideline, which I on the subsequent slides I do have some basically examples or templates websites that you can use to just develop your own if you haven't done them. But really, this was an example of a trial where they did a guideline for cellulitis and suspected abscesses. What they did is they just disseminated this guideline, this as an order set. They sent it out through email. They posted it in work areas. They put it on their intranet. So about these new guidelines for the skin and possible abscesses, and all just basically disseminating these guidelines and kind of posting it in public areas. They found that over time it reduced gram negative antibiotics by 30%. And I think they studied it to 1 year actually, so it was a long-term trial. They found that anti-pseudomonal antibiotics, they reduced those by 10%. And the combo treatment, so the more broad antibiotics like the Zosyn or the Augmentin, it reduced those by a third. Next slide. And so this was again that same trial where you see the median duration again was cut 3 days shorter. And then the shorter courses, so the under 10-day courses, those increased. So people were basically just prescribing more narrow regimens without the broader gram negative or anaerobic coverage or pseudomonal coverage for skin, soft tissue. You don't really need like that kind of broader coverage. And they were just really kind of narrowing it quite a bit. Again, all this was just a guideline that they put in and they posted that you can use this order set. So pretty simple intervention. They did look at some secondary outcomes. So they looked at recurrent infections. They looked at revisits. So like, did someone have to go to the ER? Did someone have to go to a clinic visit because they didn't have cure with that shorter duration? And they found there was no difference in the clinical failure, clinical cure when they compared that for the shorter and longer durations. Again, so just more evidence that we can use those shorter durations with confidence. Next slide. So as I mentioned, these, and you can go back to our earlier sessions too, but these are kind of national guidelines, but simplified with some options here. If you don't already have kind of facility guidelines, these would be some examples for UTI and pyelonephritis, recommended antibiotics and durations. Next slide. And then here actually is I included some kind of more drug resistant bacteria, VRE and ESBL options, because that's always, a very common scenario and common question. Next slide. And then here's the guidelines for the skin, the cellulitis, and skin soft tissue infections. And so just also clarified, like, does it have, is this looking like more MRSA or is this looking more like strep basically? But you can simplify these however you find fit for your facility. Again, short durations, 5 days. Next slide. And then just a little bit more on the skin and soft tissue. If they have a risk for MRSA or they have pus or purulence, then you're definitely going to want to make sure to cover with MRSA. But also just still the 5-day duration is the same. Next slide. And then again, just kind of a little bit more details. Again, you can simplify this however you see fit. Next slide. And then here are the community acquired pneumonia guidelines. And I included kind of the no comorbidities versus comorbidities because there would be kind of a slight change in those. Next slide. So those are all the guidelines, which you guys got on the handouts as well. So finally was going to talk about clinical decision support. So this was a huge systematic review, 43 studies, and it was all in the outpatient setting to look at reducing prescriptions. And they found that the most effective interventions to change antibiotic prescribing was really like multiple things. So using those guidelines, using in combination with the audit and feedback, so multiple things done at once, and combine that with education really was the most effective with long-term sustained impacts in reducing antibiotic use. Next slide. So this is just a kind of, you can think of this, I mean, there's so many decision support tools, really. I mean, this could be a checklist, this could be an order set, this could be, I'll show you some other examples of some really easy decision support tools that we created. But this is just some way that guides the clinician to the appropriate course of action, the appropriate antibiotic, and the appropriate duration, or I should say, maybe not even any antibiotic. Like you can see from the viral script pads in a couple slides, that really a lot of times it isn't about antibiotics at all. It's providing some alternative. But this is just the support tools that kind of help build that discussion when the physician or clinician sees that person. Next slide. So this is an example of a decision support for urinary tract infections, and this was basically like a alert was triggered when a antibiotic for a urinary tract was about to be prescribed. They actually then enter what the diagnosis is. So is it a UTI? Is it pyelonephritis? Is it prostatitis? Is it a CODI? And then there's a pop up that occurs that then gathered all the relevant electronic data. So it pulled in the the renal function. It pulled in prior urine cultures. It pulled in blah blah blah, and then it allowed them to like basically make the best choice from that. The clinician could totally opt out of this, so they didn't have to go through this workflow. They didn't have to go through this decision support tool. But you can kind of see on the right, it's kind of an example of what they look like. It's not exactly because they didn't actually publish in their manuscript have an example of it. So this is actually a kind of a snapshot I found from like another trial from like Epic, and it's sore throat. But you get the point. It's basically just kind of a step by step process. Next slide. And here was another. They can get really convoluted. This looks like maybe it's like a Cerner type one, but you can kind of see here that this is. You can do so many things in this decision support tool. You can pull in a lot if you want. You can pull out really minimal stuff, but it can really help guide the appropriate treatment for these for the decision making. Next slide. So these was a couple trials where they looked at this, and what happened when you do these kind of decision support tools is the guideline, in accordance with guideline, improves. So 50% once those tools were used, and what happened is your reduction of certain kinds of antibiotics. So they reduced fluoroquinolones by about 2/3, reduced Bactrim by about 75%. But what happened is it's more alignment with their guidelines, so they increase their macrobid use, their nitrofuran use increased by about 42%. And again, these people did not have to click on this, but what tended to happen is up front they would click on it. They got the kind of feeling of the guideline of the recommendation. The next few times they never clicked back through it, but they got that. But it also served as like an educational piece. Next slide. So this is kind of an example of a clinical decision script tool. So I have these where you just like print this out on a 5x7 pad, like actual notepad. And this is an example. I don't call it like the UTI because this is not like if they had a real UTI, we'd treat it with antibiotics. But this is kind of, you see a lot of people with recurrent UTIs, and you kind of question like, you want like a urinalysis to make sure, like you have cloudy urine, or to clear your infection, you get a UA and you don't know what to do with it. Or people have chronic things like vaginitis. And so what it shows is you can click the diet, or you can select the diagnosis so the patient knows what they have. So they have a diagnosis, but it's not urinary tract infection. Kind of gives a little bit more details of why you don't think they have it. Kind of gives guidance if they have symptoms of this and this and this, call back, or let me know. And then also on the right is really like more of symptom relief medications. All of these are over the counter except one of them under the preventative medication section, the methenamine hippurate. That actually is a prescription, and that kind of is a medication that can kind of reduce um, uh, bacterial growth in the bladder. So that is kind of an option when people have a lot of recurrent infections. I'll kind of talk to them about starting methenamine hippurate. But also on the bottom, there's dietary, hygienic kind of discussions, things to avoid, like caffeinated foods, spicy, etc. All this. So this is like a physical pad that you could do a PDF too, just do it and provide it in the visit. But what I've done is just have them actually be notepads and then provide it to the patients. They really like it. Next slide. And then this is the same thing with you've seen these are more common. These are the viral script pads. And I did these and I included it with COVID because, hey, why shouldn't our viral script pads have COVID now? But again, it's kind of that decision support tool that is drawing away from the antibiotic giving you the directions. If you have this symptom by this day, give me a call. But in the meantime, I don't think this is what you have. I think you have a viral, bronchitis, or you have a upper respiratory infection, a pharyngitis, and this is what you can do to support it. Because really, where we've done a lot of studies, and a couple years ago did a survey of patients, and really what they do want is they want reassurance that they don't need antibiotics. It's nothing more serious. But the number two thing that they want is they want supportive care. They want to know what can help them get over it. Next slide. So the very final last 5 minutes is over dental prophylaxis, antibiotic prophylaxis, and so this is another area where I feel like we're getting kind of moving for the shorter courses, but really another component where we see a lot of prescribing in our patients. And I will say, the over the past decade, there's been two guidelines. It's changed twice by the American Dental Association, so it is hard to keep up with, and there's a lot of differences. So like even in England, the UK, they have these nice guidelines, and they actually in 2008 recommended to stop all dental prophylaxis. So even people that I say they had a history of a prosthetic valve or something like that, there's no recommendation there for prophylaxis actually. So that's how strong some countries have gotten away from dental prophylaxis actually. Next slide. And then this is, and so interestingly, I did a talk for a dental group a couple like in the spring. So did a little deeper dive into what is the evidence around prosthetic joint infections and dental prophylaxis. And there's really nothing. There's been no randomized trials that really link these prophylaxis with preventing prosthetic joint infections at all. So this might be like a little bit of a dogma where over time people felt like they had to prescribe prophylaxis to prevent these, but there's really no evidence that actually does prevent anything. Next slide. And so this was, again, kind of we talk about those support tools. This is basically kind of a visual, same thing. You could put it in PDF or you can put it on an actual printout. And this kind of gives you in the green those kind of conditions per our national guidelines. What does say needs prophylaxis? So that being they've had a replaced heart valves, they have prosthetic material, they've had a history of endocarditis, that they have congenital heart defect. All those are indications for the prophylaxis. But a lot of what we're really seeing people get prophylaxis for, they have a history of a knee replacement, hip replacement, not an indication for prophylaxis. They are immunosuppressed, not an non-indication for prophylaxis. So just as like again, it's a visual guideline, visual guidance. I mean, and when you do have the indication for antibiotic on the right side is what the ADA, the American Heart Association, recommend as the frontline treatment, because that's another area where there's a lot of overprescribing. We don't need, a 3-day course for a prophylaxis. It's really one dose before 30 minutes before the procedure. Next slide. And all those tools, I will say, I think Brenna's on here too. We have been slow to get those uploaded, but but they all complete, and I'll get those sent over to Loretta too to post some updated on their website, because I think you emailed me like a month ago, Loretta, about the updated viral script pads, and I'll send you those GU ones and also the dental ones too if anyone's interested, and it gives directions on like how you print those out and stuff.
Be great.
So Tanya asked, I think we struggle with the difference between bacteremia versus UTI versus colonization. Do you have any suggestions on how to educate what the differences are? And I will say, so this is number one, like Loretta and I were just talking about this before the webinar started, is really this is something think needs so much more education and more work. Our first session, actually, there's pretty much probably a good maybe the first quarter of that session was actually dedicated to the differences on the colonization and how to differentiate colonization versus infection, when to get urinalysis, how to stop unnecessary urinalysis, how to do this communication strategy that nurses can have, even some examples of some scripts like this, some phrases, how to communicate this back to the clinician, to try and cut down on the amount of those even ordering those cultures. So I would check that out. And this is something we've talked about, really having in the future more kind of like a dedicated initiative to really targeting this. If anyone's interested in that, please let us know. We really, this is why we formed this kind of session, is from feedback from everyone. So
If there's any other questions, feel free to take yourself off mute, or you can put a question in the chat. Okay, well, if we don't have any questions, want to thank Dr. Wark for wrapping up this series with a wonderful presentation. And also thank you everyone for joining us for this series. We've had great participation with this during the live portion, as well as viewing those recordings and accessing those handouts. In case you did miss any of those sessions, they can be accessed on the KFMC news and events page, and I'll be sending that link out to you as well. Upon ending today's webinar, the evaluation should appear. So please do take a couple of minutes to provide your feedback. That's really helpful as we plan future education. I'll give just another second there in case anyone has any questions before I end the series or end the webinar. All right. Well, I'm not seeing anything, so we'll go ahead and give you a minute or two back in your day. And thanks again, everyone.
thank you.